Now I'm opening the session. So I kindly invited Assaad SOWEİD for his nice speakers. Please, Assaad SOWEİD.
Thank you, Mr. Chairman, and thank you, everybody, my esteemed colleagues. It's always a pleasure to be in Turkey. This is maybe my 15th visit to Turkey, which I consider my second home. And I am, for those of you who know me, I am professor of medicine at AUB in Lebanon, but I moved to the United States for 1 year leave, 1 or 2 year leave. So I'm now working in Washington, D.C. for a year or two, but it was a nice flight from Washington, D.C. to Istanbul and then to Antalya. So it's a pleasure to be addressing my colleagues, and a lot of them are surgeons, and trying to give you some updates on endoscopic ultrasound, which is a field that is very close to surgeons, and try to show you that this is a field that will help surgeons a lot. So I'll talk in general about EUS for people who don't know much about the technique, and then I will talk about mainly the new modalities of endoscopic ultrasound. So endoscopic ultrasound is basically looking outside the GI wall. And this is basically done by examining the lumen, but then the ultrasound part will look at the structures inside the wall of the gut, any part of the gut, esophagus, stomach, small bowel, and colon, or the organs that are around it, namely the mediastinum, liver, biliopancreatic system. There are two ways of looking, either with a radial scan, which we are no longer using much, or with a linear, which is better because it gives you also the capability of putting a needle in and getting some biopsies. And we use a lot of terminology. This is more familiar among our radiology colleagues, like echogenicity. If it's black, it is anechoic, which is usually liquid, and then you can have isoechoic, which is the same as the adjacent structures. You can have hypoechoic, which is mostly malignancy, and hyperechoic calcifications or stones. So this is the language we use when we describe things on endoscopic ultrasound. But the interesting thing about this technique, as all of you know, is that it gives you a dissection. We're doing a dissection of the GI tract wall, and this is the correlation between what we see on EUS and the basic histopathology and histology of the gut wall. Some of the images we can see obviously organs outside, common bile duct, pancreatic duct, portal vein, gallbladder, and these are important later on for therapeutics, what we can do as procedures. This technique, all of you know, is important for staging of malignancy, luminal, mainly esophagus, stomach, rectum. It has its limitations. I'll show you how we bypass these limitations. And it's important specifically for our surgical colleagues to know what the stage is before we plan any treatment, because the treatment depends on the stage, and the stage, at least the T and the N, are mostly determined by endoscopic ultrasound. This is also some of the uses, some data we published on MALT lymphoma, which is a very, well, not very common, but a common type of treatable and curable lymphoma that we see that is related to Helicobacter pylori. So briefly, I'm going to go over the indications. Pancreatic cancer, we know it is the best modality, the most accurate modality to detect and to diagnose pancreatic cancer, especially in the regular pancreatic cancer, less than 2 centimeters in size, when it is missed by other modalities, namely MRI and CT, and for pancreatic neuroendocrine tumors, even if they are in the order of less than 1 centimeter. This is an example of very, very obscure neuroendocrine tumors, and this is a larger tumor, but even few millimeter tumors can be accessed. Also, it's important in pancreatic cysts. We see a lot of cysts, and I'll show you why looking at the cyst might not be enough, but putting a needle might give us more information, because morphology of the cyst alone, looking at the cyst, cannot tell us for sure if this is a malignant cyst, or it's a mucinous cyst, or it's a serous cystadenoma, etc., etc. Sometimes doing the puncture will make the difference. Another indication for EUS is subepithelial lesions. All endoscopists know that a lot of what we see during endoscopy are subepithelial lesions. We don't know what they are. These look similar, but they can be cyst, a tumor, lipoma, or even varices. How do we make the distinction? Well, by EUS, by looking at the layer of origin, because the layer of origin correlates with the pathology. And basically, if we see a flow, for example, that's a varix. If it's an anechoic, it's a cyst, etc., etc. So this is very, very important for determination of subepithelial lesions. Stones, the stones are very important because we lately published a series on 590 patients with stones, and we showed that with EUS, you can determine with a very high level of accuracy and speed within 5 minutes of exam, presence or absence of a CBD stone. And this would obviate the need for an ERCP in a vast majority of patients, even ones that were classically deemed as high risk. That is, if you look at patients with high risk that you thought need only an ERCP, if you do an EUS and you find a stone, then you would need an ERCP. But 2/3 in our series did not have a stone, although before the exam we thought they had a stone prior to EUS. So there are limitations. That's why the newer developments, which are still older, are how do we determine if lymph nodes are malignant or no? If there is a tiny lesion, how do we bypass it, and how do we obtain tissue? And this is done by newer tools. This is, for example, some of the data on the mini probe. It's like a biopsy forceps. You can put it in a gastroscope, colonoscope, duodenoscope. You can look at the pancreatic duct, at the lumen, for example, Crohn's disease, ulcerative colitis. This is done during an exam, and it's extremely helpful. In this case, we have a stricture in the upper part of the common hepatic duct. This is the mini probe, and you can see that there is a significant tumor adjacent to the hepatic artery. So it's another way of looking at lesions in the small luminal organs like the common bile duct, the pancreatic duct, etc. The linear one would provide us the ability to get a biopsy, and this is also quite important because many times, as we say, tissue is the issue. We need to get tissue diagnosis before we decide on treatment. And EUS gives us this capability. In this case, we have an adrenal lesion, and we are biopsying it through the gastric wall, and this ended up being an adenocarcinoma metastatic from a lung, non-small cell carcinoma. So the advantages of FNA is that it detects small lesions, it gives you tissue diagnosis, and the biopsy through the gut wall is very comfortable, especially for our surgical colleagues, because it decreases the risk of seeding, especially if we're biopsying through a gut wall that's going to be removed, like, say, in a Whipple type of procedure. I'm not going to go a lot about the technical details, but we know that we have many needles, and we are moving away from FNA to FMB, which is fine needle biopsy. And there are many types of big needles to obtain biopsies, different in the market. And we need them because they give us bigger core. We can do immunohistochemical testing. We can get better tissue. Even our oncology colleagues are requesting tissue diagnosis, not cells, to determine if the patient would need and what type of chemotherapy. So this is why obtaining a biopsy is more important than an FNA. And again, in pancreatic cancer, we know that this is a very accurate technique, and we can do it. In this case, you can see the needle going under ultrasound guidance, and that's a large pancreatic head mass. And again, this would determine whether the patient will go for surgery or do any kind of treatment. This is a very tiny lesion. This is a 5 millimeter lesion in the head of the pancreas. And the biopsy, you can see it's hardly 5 millimeters, a little bit less. And this is how the needle is moving in, and the diagnosis was a pancreatic neuroendocrine tumor. We can get a core biopsy and determine the Ki-67 and many other things that are needed for grading and staging of these tumors. So why is it important if you have a mass in the pancreas? This is a table that I gathered from all my experience, and it shows you what are the solid lesions that would not need a Whipple by per se or surgery. For example, neuroendocrine tumors, maybe limited type of surgery. Solid pseudopapillary lymphoma needs chemo. Metastatic lesions need treatment, not surgery per se. And then you can have focal chronic pancreatitis, autoimmune that would need steroid treatment. So all these entities might mimic a mass, but they are not a mass, and EUS is the only way to detect those. Also in cysts, looking at the cyst might not enough. If we put a needle and we look at the viscosity, amylase level, CA19-9 level, cytology, etc., we can get a very good idea if this is a pre-malignant, that is a mucinous tumor or no. So again, when we put a needle inside a cyst in the pancreas, we determine the CEA level, cytology, and we can also do molecular markers such as GNAS or KRAS to determine if this is a mucinous cystic neoplasm or an IPMN, etc., etc. So this is also very helpful. In addition, for people who don't know, EUS is done very frequently in the lungs. So we often get a lot of consultations by our cardiothoracic and pulmonary colleagues regarding performing EUS for the staging of non-small cell lung cancer. We can also get biopsies from masses in the lung itself if it's close to the esophagus, and of course other lesions that might determine metastasis such as the adrenal glands. So again, these are the stations of the lymph nodes, and I'll show you which are the ones that are accessible by EUS. And these are the lateral ones, levels 2, 4, and the AP window, which is level 5, subcarina, which is the most common, 7, and then the lower ones, stage or the level 8 and 9, station 8 and 9, which are adjacent to the esophagus. So this is also helpful in the mediastinum, and there are many indications, probably as much as GI indications in the mediastinum. So let's move now to the basic part of this talk, which are what are the new developments? What are the new techniques for endoscopic ultrasound? I'll start with elastography. Elastography basically is a major recent advancement, and it depends on compression of a target tissue by the probe. So if the color is blue, that means it determines that it's hard, which is usually malignant. If it's green, it's soft, it's usually non-malignant. So in a way, it can help us characterize a lesion better, be it a lymph node, be it a cyst, be it a solid lesion, into what it can be. This is an example of a benign and malignant. For example, this is all greenish and ended up being part of the chronic pancreatitis. This is very well-defined blue. This is basically most probably malignant. And this can help us also guide where the needle is going to go. If we go, for example, to the interface between the two, we can get better yield. If you go only to this, it might be very hard, desmoplastic reaction, not many cells. And if you go into this soft part, it would be necrosis, so we don't get a lot of tissue. So this technique gives us a virtual biopsy that would help us in determining what the lesions are. This is another example. For example, on the left part, you can see a pancreatic teratoma. Here it looks like a tumor, but teratoma is basically shown in the green pattern. While in this part, it's all bluish. This is pancreatic classic ductal adenocarcinoma. Of course, then you will have to probably get a core biopsy and determine that, but that's an adjuvant type of diagnostic technique. Other thing that I've been doing a lot, and there's a lot of literature to support it, is contrast-enhanced EUS, which is basically injection of microbubbles in the vein and waiting for certain seconds, usually within 1 minute, and then looking where the bubbles go to where vascularity is. And this is an example of the SonoView, which is the microbubble solution. And in this case, you can see that this is a cystic lesion, and there's something inside it that looks scary. It looks like a nodule. So maybe this is cancer. Well, this one, too smaller nodule. But when we did the contrast enhancement, it did not take the contrast, which means it's only a mucus plug, while these lit up, which means they're probably malignant nodules. So this can be extremely helpful to determine nodules inside a cyst or even regular solid tumors. We also have the capability, if we have a cyst, for example, to put a needle, microneedle. It's a Morey microneedle, and it's a very tiny needle that we can put inside the biopsy forceps, inside a 19-gauge needle. So we can go inside the cyst and obtain a biopsy. And this is an example. So it's the needle, but then the biopsy forceps is pushed inside the needle. It's a very tiny one, and we can go to the wall of the cyst and obtain biopsies. And it's very, very safe, and the yield is much better than aspiration alone because it gives you an idea about the lining of the cyst. Another technique is confocal laser endomicroscopy. And this is basically another thing that we put inside a 19-gauge needle. So it is the best way of describing it, it's kind of like a microscope. So we're putting this next to the tissue and determining what kind of tissue we're seeing. And this is the view we can see. So you can see basically the cells and the pattern of the cells. And depending on the pattern of the cells, at least in cystic lesions, you can determine if it's a serous cyst adenoma, MCN, mucinous cystic neoplasm, IPMN, pseudocyst, or even a cystic neuroendocrine tumor. Unfortunately, the inter-observer agreement is still not very high. It's a learning curve, but it's one technique of looking at microscopically in vivo using the endoscope and the EUS scope at the mucosa of a cyst or even solid lesions to help us determine the nature of this lesion. Now, can we do something? All of this has been diagnostic. What about therapeutic? What can we do with that? Well, a lot of things. So I'm going to discuss the main thing we do therapeutically. Celiac plexus neurolysis and block, pancreatic pseudocyst drainage, FNI, fine needle injection, be it for immunotherapy, gene therapy, alcohol, tattoo, and then fistula formation, biliary or pancreatic like bypass, implantation of seeds, fiducials to help our radiation therapy colleagues target the tumors, ablation with radiofrequency, and gastroenteric anastomosis. So let's start with the nerve blocks. We know that the celiac axis is very nicely visualized, the aorta and the celiac axis and the celiac artery, and this is the celiac plexus, even the celiac ganglia. So in case you have patients with chronic pancreatitis and a lot of pain, we can target this area with a needle, and we can target even the ganglia and inject steroids. You can inject basically things like lidocaine, like anesthetics, but not alcohol. Alcohol, if we inject alcohol, it will be a celiac plexus neurolysis. This would be killing the nerve. That is reserved for patients with malignancy-related abdominal pain. This is, again, the aorta, the celiac artery, the SMA, and this is where the injection is. And celiac plexus neurolysis with alcohol injection has been shown to produce reduction in 80% of patients up to 6 months. And I've seen it a little bit shorter and a little bit longer. But unfortunately, the block doesn't have a sustained response. We do the blocks only on chronic pancreatitis, not on patients with pain related to malignancy. How about the drainage? We all know that pseudocysts can be big, they can produce symptoms, and when they are mature, they need to be drained. And I'll show you how we can do that. Now there is the one system, it's basically like the hot axis or other systems where you can gain access and put a lumen opposing stent. But the concept is simple. You need to identify it by EUS. You need to perforate it by a needle knife, by cystotome to gain access. Then you have to pass a guide wire. After you pass the guide wire, we have to dilate the track by many ways. Balloon is one of the favorite ones. Or if it's a cystotome, we just dilate it with the cystotome. So the idea is dilation. And then we place stents. The stents in the pancreatic pseudocyst can be a double pigtail. 7 French is fine compared to 10. We don't need to place 10. And if it's a wall-off necrosis, which means very thick walled-off necrosis after at least 4 to 6 weeks, then we can have to put a bigger stent like the lumen-opposing stent like you can see here. And this will help us drain the entire complicated walled-off necrosis. What about the biliary drainage? Well, this technique gained popularity because sometimes we cannot do any RCP. It's either very difficult, or there's a tumor blocking the ampulla or blocking the bile duct, or there's a tumor blocking your way in the stomach. Well, we can do biliary drainage by EUS, and we can do it in one of 2 ways. If the bile duct is blocked from level of, let's say, Klatskin tumor, we can identify through the stomach a dilated left hepatic duct, and then put a needle in, and then this will help us place a stent. Metallic stent or plastic stent, we prefer metallic stents. By this, you're creating a hepatico-gastrostomy, so we are bypassing the biliary obstruction. We can also do a choledochoduodenostomy, which means going down. If the bile duct is dilated and we can make it to the duodenum, there we can do it transduodenal. This is easier, and we can put either a plastic, but the preference is also putting a metallic stent, and namely the lumen opposing stent. Drainage of gallbladder is becoming more and more popular. We have older patients, sicker patients, not surgical candidates who have acalculous cholecystitis, and what we do is we place lumen opposing stents. The scope is placed in the duodenum. We identify the large, basically dilated gallbladder, and we pass a guide wire, and then we place the stent for internal drainage of the gallbladder. I had a series of patients on drainage of abscesses in the pelvis adjacent to the rectum or the sigmoid, where we can do the same. Either we drain it one time, or we can place a plastic or a metallic stent. So basically, drainage of cystic structures adjacent to the GI tract is one of the indications of this therapeutic technique. Injection didn't gain much popularity, but I can tell you there are trials on lymphocyte cultures, injection of chemotherapy, adenoviruses that replicate in tumor, even ethanol, alcohol injection, specifically for cystic lesions, small neuroendocrine lesions, if they are not surgical candidates. And these are some examples of alcohol injection and injection of chemotherapeutic agent. We can also use a lot of data on use of radiofrequency ablation. So again, the needle is placed, let's say in a pancreatic mass, patient is not surgical candidate, locally advanced, and it showed that if you place the needle and you apply radiofrequency to this catheter inside the needle, then we can produce an effect beyond burning it. There is some misunderstood pathophysiology that would help the tumor to shrink using the radiofrequency ablation. That can be done under EUS guidance. We're doing a lot of placement of fiducials. We do have needles that can place 3 or 4 fiducials at the same time, and we can use them to mark a tumor by placement of these fiducials that are usually gold. And then our radiation oncology therapy colleague will come in and will target this area if there is need be. Tattooing is important. Lymph nodes can be tattooed with India ink. Small neuroendocrine tumors that are hard to be found by our surgical colleagues can be also marked by EUS and India ink tattoo, and then during the operation it will be much easier to find. Evolving vascular implications or applications, which is very interesting. We were thinking that, putting a needle inside a vascular structure is contraindicated. Well, there is data on using the EUS for helping us place coils or treatment of gastric varices and other forms of treatment. But I'll tell you, this is pseudoaneurysm, embolization with coiling, but this is instead of from the outside or intravascular through an EUS-guided technique. And the latest kid in the block is the gastroenteric anastomosis. And this is basically done if you have a gastric outlet obstruction, and you need to do, instead, a patient is very poor surgical candidate, so you can bypass the obstruction by creating a fistula between the stomach itself and a dilated part of the bowel. And that can be done by many techniques, either by filling with water or putting a certain catheter with balloons, so we can fill the lumen of the jejunum that we're going to bypass, and then we can pass a guide wire and put a small lumen opposing stent, so we can bypass the stomach, and we'll have a gastroenteric anastomosis. So that's a very interesting and evolving technique. And this is basically how it looks after we do the bypass. So it is the stomach that is dilated and obstructed, and this is the lumen opposing stent, that food will come in and go through the stent into the jejunum, thus bypassing the obstruction of the stomach. So in summary, EUS has evolved a lot over the past 25 years. It's not merely an endoscopic diagnostic tool, but it's evolving more and more into a therapeutic technique. It's associated with a lot of advancement that took place in terms of mathematics and physics and optics, namely the confocal, the elastography, etc., radiofrequency ablation. So in my opinion, sky is the limit. And the boom in these technologies translated well into the EUS. And I do believe that these techniques are helpful, namely the elastography and the contrast enhancement as far as diagnosis. EUS also is very important in staging, again, as we know, of tumors, and in addition to GI, mediastinal and lung non-small cell carcinoma. The application of mini probes and the FNA improves the yields, improves the diagnostic capability, and the newer techniques have nothing but potential to the future. And I do believe that the therapeutic arm of EUS is going to continue to evolve, and it will help it become the surgeon's best friend. Thank you very much for your attention.
Dr. Assaad, thank you very much.
Thank you.
Really nice and kind presentation.
Thank you.
So we can take one or two questions, maybe. Please come to microphone. Who wants to ask questions? Sorusu olan varsa arkadaşlar mikrofona buyursunlar, kendilerini tanıtarak.
Doktor Ömer Günal.
Ömer Hocam, soruları çok özür dilerim. Yavaş söylerseniz İngilizce tercüme eden arkadaş biraz daha kolay yapabildiğini söyledi. Lütfen eğer Türkçe soracaksanız biraz yavaş.
İngilizce de sorabilirim, fark etmez, nasıl isterseniz.
Siz nasıl isterseniz, evet.
If you don't mind, I would like to ask my question in English.
Yes,
Yeah, right,
sure.
okay. And do you have any indications, especially in the usage of cystogastric interventions, especially, for example, pseudocysts or walled-off abscesses?
Yes.
And what are your indications? And do you perform needle knife? Do you use needle knives without putting double pigtail catheter? Do you perform a cystogastrostomy operation as endoscopically?
Yeah. Thank you very much for the question. So, first of all, there is definitely a difference between a pancreatic pseudocyst, which is only water-filled, and a walled-off collection necrosis that is very thick with a lot of material. So let's start with the pseudocyst. If we can tell a priori if this is a pseudocyst by MRI, ultrasound, etc., and if we decide it is a pancreatic pseudocyst and it's symptomatic and it's mature beyond 4 weeks and the patient is symptomatic, yes, we have to drain. And the drainage in the past used to be done by a needle knife without even an EUS, but that's dangerous because of the risk of bleeding. But it can be done, but in case there is no EUS, I advise against it because the EUS would help make it safer. But if a needle knife is done under ultrasound guidance and you open it, you have to dilate the tract with a balloon, and then 2 stents have to be placed, because otherwise, even if it's big, it will close. The cyst is not going to drain. We have to keep 2 double pigtail plastic stents, and the size in the past 10 French. Now 7 French is enough. There is some data on putting them in different parts, not in the same hole, but I think both are fine. So if you do them in the same opening or in 2 different openings in the stomach. But it can be done by a needle knife, it can be done by a sphincterotomy, it can be done by putting a needle through EUS and then putting a guide wire, or it can be done by a cystotomy. So many techniques, but the concept is the same: open, dilate, and put a stent. Regarding your other question, the walled-off necrosis, the stents don't work. You have to use a big lumen-opposing stent, and some of them are big as 1 to 2 centimeter diameter. So once you put that, then you can go in with the gastroscope inside the walled-off collection and help drain the debris with a snare, with a basket, with lavage. So yes, you can do it, but you need a big lumen opposing stent. The longer stents are not designed for this, so we don't use them. The small lumen opposing are excellent, and they can be removed at the end when this basically collapses and it's completely drained.
What should be the removing time of the drain and removal time?
Oh, it depends. It depends. Usually it takes 1 or 2 or 3 months. Depends on if it's shrinking, what size. When it's usually smaller than 3-4 centimeters and the necrotic material is gone, you can pull it out. So it's not like permanent. It can be pulled out, but depends on the size, on the presence of debris, and what you have done endoscopically. If you cleaned it all and it's beginning to collapse, yes, it can be removed. It doesn't have to go to zero. Few small centimeters are fine. 3 to 4 centimeters are
Right,
fine.
thank you very much.
Thank you,
If
Mr.
you don't mind,
Ömer.
one more question, can I ask, about morbid obesity?
Buyurun, peki.
In Roux-en-Y operations, do you have any expertise in these kind of patients to do the bile duct and ultrasonography?
Yes.
Especially in
Yes.
Roux-en-Y.
Yes. This is basically when you do for patients who had Roux-en-Y, basically bypass, when it is, let's say you need to do an ERCP and there is no way you can access the ampulla. One technique is to go through the remnant stomach and access the native stomach and put a lumen opposing stent, a large one. Once you do that, then you can pass a scope through the stent itself and do a regular ERCP. So it has been described. I personally have not done that, but it's been described. Like a lumen opposing stent from the bypassed stomach pouch to the native pouch, to bypass them, so creating a lumen and then going through it, through the ampulla, and doing an ERCP, and then going back. And when the indication is gone, this can be removed.
Right, thank you very much.
Sure.
Thank you, Mr. Ömer. Yes, Mr. Hassan. The last question.
My question is about the seeding of tumor.
Yes.
During the FNAB or FNAA, the distance from the stomach wall to tumor is important or not?
Yes.
The distance is maximal distance.
Yes, this is a very important question. I'm glad Dr. Hassan asked me this question. Well, the initial data is like, why is EUS safer seeding-wise compared to a CT-guided biopsy? Well, we know it's safer, but there are many reasons for that. Number one, if you're getting an FNA in the head of the pancreas or neck, it's easy because there is no much distance outside, and if you do a Whipple, it will be a part of the Whipple sample. But the data came from our Japanese colleagues that looked at lesions in the body and tail, especially cystic lesions. So they showed, at least in a few case reports, that if you do a transgastric biopsy, it can produce some seeding. So the risk is low, but it is there. So if it's a body or tail lesion, specifically a cystic lesion, there can be seeding. It goes back to the risk and to the benefit, but at least data-wise, there is data that it is safer, and there is a study done at Duke in North Carolina that looked at patients who had CT-guided biopsy versus EUS-guided biopsy in all of the pancreas, and the seeding is much less with an EUS-guided biopsy. But I would take your question very seriously that there is still a risk of seeding, specifically if you do it in the body and tail, so you have to weigh the risk and benefit. For example, a young man with a solid lesion in the tail of the pancreas looks malignant, and by elastography, by EUS, I do not biopsy for the reasons that Dr. Hassan said. Because even if there is a small chance of seeding, this is a young man. So I would send for surgery immediately. So you have to individualize. So the risk of seeding is less, and it's higher if there is a longer distance between the lumen and the organ, like in the body and tail of the pancreas from the stomach, rather than the head of the pancreas.
Thank you very much for these questions. So thank you, Mr. Dr. Assaad SOWEİD. See you again next Congress, I hope.
It will be my
Thank
pleasure.
Now we are going to...
Pardon hocam. Asad hocamıza şimdi Profesör Doktor Hasan Bektaş hocamız bir plaket sunacak. Buyurun
okay.
Hasan hocam.
Teşekkür ederim yalnız. Evet. İyi oldu.